acute limb ischemia.
Yeah.
The stakes couldn't really be higher for vascular surgeons, could they?
No, absolutely not.
Even with all the amazing progress we've seen elsewhere in vascular treatment, losing a limb or, worse,
Yeah.
it's still a very real threat.
It really is. And often it's tied up with other serious health problems the patient has, which just makes it incredibly challenging to manage.
Yeah.
What really jumps out from the reading, I think, is how critical that initial clinical assessment is. Rutherford's really hammers home that experience and just sharp clinical judgment are absolutely foundational.
Right.
Making a mistake there, I mean, the consequences can be really severe for the patient. It highlights the pressure.
Definitely.
So,
Okay, so let's dive in. For this deep dive, we're going straight to the source, really. Section 14 of Rutherford's Vascular Surgery and Endovascular Therapy, chapters 103 through 106.
the definitive guide.
Pretty much. Think of this as trying to build an instruction manual, pulling directly from the experts. Our aim today is to pull out that essential knowledge, a practical guide for managing acute limb ischemia.
Cutting through the complexity.
Exactly. Getting straight to the actionable stuff you need.
Right. We're trying to distill what a vascular surgeon needs to confidently navigate these really demanding cases. Rutherford's is the standard, so these chapters, they represent the core principles.
Okay, let's kick off with Chapter 103, Evaluation, Decision-Making, Medical Treatment. It lays the groundwork.
Mm-hmm.
And it starts right off with the two main culprits for acute limb ischemia, putting aside trauma and iatrogenic causes for now. We're talking embolism and thrombosis.
Yeah, and the key difference is how the blockage happens.
Yeah.
Embolism is like a sudden obstruction, a piece of something, often a clot from the heart, maybe some athero debris from the aorta travels downstream and just gets lodged.
Usually where an artery splits, right?
Exactly. Bifurcations are classic spots, like
Yeah.
the common femoral or popliteal in the legs or the brachial up in the arm.
And then you get those really dramatic saddle emboli
Yeah.
right at the aortic bifurcation.
Yeah, thankfully rare, but serious. And embolic events, they tend to be quite dramatic because the artery might have been totally fine beforehand. No time for collaterals to develop.
Rutherford calls it catastrophic.
And that's often accurate. What's also really important is that this first blockage, it often triggers more clotting, secondary thrombus, both upstream and downstream.
Ah, all right.
And that secondary clot is often what you're actually dealing with when you do an embolectomy. So embolism is sudden, often needs immediate attention.
Okay, so then the other side is thrombosis, a clot forming right there in the artery itself.
Correct. Usually because of underlying atherosclerotic plaque buildup. The artery narrows, and then bang, a platelet clot forms on that rough surface and blocks it off completely.
But the presentation can be less sudden compared to an embolism.
Often, yes. Because atherosclerosis takes time, the body might have developed some, detour routes collateral, so the symptoms might creep up more slowly.
Makes sense.
But thrombosis can also happen because of hypercoagulable states. The chapter mentions cancel links, HIT.
Heparin-induced thrombocytopenia.
Right. Or vasospasm. Sometimes aortic dissection can look like an iliac occlusion or even bypass grafts clotting off. And sometimes just a sudden drop in blood pressure in someone with bad PAD can tip them over into ischemia.
So thrombosis is often more about the underlying diseased vessel.
Exactly. A sign the plumbing itself needs attention long-term, even after you fix the immediate blockage.
So how does this all actually look clinically? What are the signs and symptoms you need to be watching for?
Well, it really depends on the artery size and those collaterals we mentioned. Block a big artery with no backup. You'll see that classic severely ischemic limb,
Well, a smaller one.
like the SFA maybe. If the profunda is wide open and there are good collaterals, the patient might not even have that many symptoms initially. But one early warning sign the chapter points out is sensory nerve loss. That's key.
Okay, then the actual assessment. History and physical. Duration sounds critical.
Absolutely critical. Severe ischemia. Irreversible muscle damage can start within 6 to 8 hours. So someone reporting sudden severe pain plus sensory or motor loss. That's a true emergency. Go time.
And the history helps differentiate cause.
You try. The old idea of embolism in valve patients versus thrombosis and claudicants is, well, it's getting blurrier. But you still ask about prior claudication, full medical history, diabetes, risk factors, all of it.
And the physical exam. The rule of fees still relevant.
It's a helpful framework, yeah. Pain, pallor, paralysis, pulse deficit, paresthesia, perishing cold. Still useful.
What do they tell you?
Skin color gives you an instant read on flow. That marble white look means severe ischemia. Capillary refill, distal perfusion, sensory loss, light touch, proprioception, that's an early warning. Muscle tenderness, especially the calf, suggests more advanced ischemia.
And pulses, obviously.
Obviously. Helps locate the blockage level. But, and this is important, a strong proximal pulse doesn't rule out a distal occlusion. That water hammer effect can fool you.
Ah, right.
And you also need to look for the source of an embolus, potentially. Any aneurysms, aortic, popliteal, is the heart rhythm irregular, like AFib?
So the clinical picture often points you to the location. What about specific spots? Aortic occlusion sounds bad.
Very bad. High risk. Usually presents dramatically, both legs paralyzed, modeling way up above the groin, no leg pulses at all, and a big risk to the kidneys, especially if it's dissection related.
Embolic.
Similar, but usually just one leg. Lose the femoral pulse on that side, modeling up to the groin. Got to rule out dissection there too.
Femoral popliteal is the most common.
Yeah, by far. How bad it is often depends on that deep femoral artery, the profunda femoris. If that's open, it helps. And interestingly, you might still feel a strong femoral pulse even with the block lower down.
And below the knee, popliteal and infrapopliteal.
That'll give you calf ischemia. You might still feel femoral or even popliteal pulses. The chapter mentions rarer causes here too, like entrapment or cystic adventitial disease.
What about popliteal aneurysms?
Ah, yeah. Thrombosis or embolization from a popliteal aneurysm is particularly sinister. Often wipes out the runoff vessels distally. Prognosis can be poor even if you fix the aneurysm itself. Tibial emboli are less common and tricky to treat way down there.
Okay, this leads to classification. Sounds like we focus more on severity now, not just cause.
Exactly. It's less about proving embolus versus thrombus right away, and more about grading how bad the ischemia is. The SVSIS, CVS, and later TASI classifications viable, threatened, irreversible are based on clinical signs, Doppler findings at the bedside.
And why is that classification so important?
It dictates urgency.
Yeah.
And prognosis. A viable limb, you might not rush into aggressive intervention. An irreversible limb, maybe the focus shifts to palliation or preparing for amputation, not revascularization. It guides the whole management pathway.
Got it. So assessment done, severity classified. What's next for investigations? Imaging.
CTA, computed tomographic angiography, that's really become the workhorse now.
Why CTA?
It's fast, it's available almost everywhere, and the image quality with contrast is excellent, often comparable to traditional arteriography. Great for aortoiliac, pretty good for infranguinal too.
Any downsides?
The main one is contrast nephropathy risk. Kidney injury. So you often prehydrate patients, especially if their kidney function isn't great to start with.
What about other imaging? Ultrasound, arteriography, MRA.
Ultrasound can give some info. Transfemoral arteriography is still valuable, but often more selective now, maybe after the CTA or during an intervention. MRA, generally too slow, less available acutely, not as useful in this setting.
And echo, checking the heart routinely. Does that change immediate management?
It's debatable. Often it doesn't change the immediate plan because most embolic patients will need long-term anticoagulation anyway.
But sometimes it's helpful.
Yeah, definitely useful in younger patients if you strongly suspect a cardiac source or if it influences long-term anticoagulation decisions. But Rutherford's notes, limitations, image quality varies, hard to see the left atrial appendage well sometimes, and a normal echo doesn't completely rule out a cardiac source.
Okay, diagnosis is clear, severity assessed. What about that immediate initial management before the big intervention?
Anticoagulation right away.
Right.
Especially crucial for emboli to stop that secondary thrombus forming downstream.
Heparin.
Intravenous unfractionated heparin, usually.
Yep.
The advantage is it's quickly reversible with protamine if needed, unlike low molecular weight heparin. We use weight-based protocols, monitor the APTT closely, aiming for 2 to 3 times normal because patient responses vary.
And other supportive stuff.
Just good basic care. Oxygen, FAR-V fluids, especially for kidney protection after contrast, monitor urine output, baseline bloods, kidney function, CBC, maybe a thrombophilia screen if it's recurrent thrombosis.
Right. Then the main treatment paths. Not just one way to fix it.
Definitely not. Big range. Anticoagulation alone sometimes, open surgery, or endovascular techniques, mechanical thrombectomy, thrombolysis.
When would anticoagulation alone be the answer?
Usually only if the limb seems likely to stay viable without anything else, or if the patient is just too sick for anything more invasive.
Class I, maybe?
Stable class I, yeah. Or class 3, irreversible ischemia to stabilize before an amputation. But it's rarely the definitive treatment for most acute limb ischemia.
Then open surgery. The Fogarty catheter was huge, wasn't it?
Oh, massive. Introduced in '63, changed everything. For a long time, surgery was the way. But disease patterns have shifted. More complex patients now, underlying PAD.
So simple embolectomy isn't always enough.
Less often, especially for thrombosis. You often need bypass surgery, too. Today's surgeon really needs the full toolkit open and endo skills.
Which brings us to endovascular options.
Right. Mechanical thrombectomy devices to physically remove the clot and thrombolysis using clot-busting drugs. Both are major players now.
So how do you choose? Surgery versus endo.
It really depends on the center's expertise, the resources, and how severe the ischemia is. Big reviews, like Cochrane, haven't shown a huge difference in overall outcomes between starting with surgery versus endo.
But maybe some newer trends.
Some recent registry data hints maybe lower mortality with initial endo without more amputations, though endo might cost more. Open surgery definitely still has risks, morbidity, limb loss.
And thrombolysis.
Good option sometimes if surgery is tough or the distal vessels are blocked. But results aren't great in really high-risk patients.
What about the overall prognosis? Still sounds tough.
It often is, sadly. The patient's general medical state, recent MI, poor heart function, that's a huge predictor of survival. Things like the PS-SUM score can help predict risks.
Sometimes it's end of life.
In some frail, elderly patients with lots of comorbidities, acute limb ischemia can be part of that final decline. Agonal thrombosis. Palliative care might be the right path. Similar considerations for advanced cancer patients with hypercoagulability. You might get flow back initially, but the cancer dictates the long run.
Briefly, upper limb ischemia and COVID.
Upper limb is way less common. Causes like thoracic outlet, subclavian aneurysms, dialysis, fistula issues. COVID didn't necessarily increase cases, but managing it in COVID-positive patients was harder. Maybe worse outcomes, younger patients affected sometimes. Recommendations were CTA aeroteliacs, high suspicion early testing, PPE, favoring local regional anesthesia if possible, and thromboprophylaxis.
Okay, let's shift gears. Chapter 105. Compartment Syndrome. Something we definitely want to avoid or catch early.
Absolutely. It's a nasty one. Basically, pressure builds up inside a closed muscle compartment. Gets so high it crushes the small blood vessels, the capillaries.
Impairs perfusion.
Exactly. The chapter even mentions Poiseuille's law. High pressure messes with the pressure gradient driving flow and can even collapse the capillaries. If it's not treated fast, muscle starts to die within hours.
What kind of things cause that pressure buildup?
Lots of things. Vascular causes, like reperfusion injury. You restore blood flow after ischemia, especially if it was longer than 6 hours or collaterals were poor, and swelling occurs.
Makes sense. Bleeding too.
Yep. Bleeding into the compartment. Ruptured popliteal aneurysm, maybe post-op bleeding if someone's anticoagulated. Then non-vascular causes are common too, fractures, especially tibia and forearm. Crush injuries. Bad soft tissue damage, burns, even just tight casts or bandages.
And iatrogenic causes, things we do.
Oh yeah, 5E fluids leaking out, extravasation, accidental artery injections, bleeding after punctures if someone's coagulopathic or anticoagulated. Even just how a patient is positioned for a long surgery, like lithotomy.
And secondary compartment syndrome.
Right. That's in trauma patients without a direct limb injury. Thought to be due to the body's systemic inflammatory response and getting tons of IV fluids. The key is anything increasing volume or decreasing space in that tight fascial envelope.
How does it typically show up? What are the red flags?
The classic sign is pain. Pain that's way out of proportion to what you'd expect from the injury, and it doesn't get better with immobilization or standard painkillers.
Okay. What else?
Paresthesias, tingling, numbness, distally. That's nerve compression starting. On exam, the compartment feels tense, swollen, rock hard sometimes. And crucially, pain with passive stretch of the muscles in that compartment.
Like extending the fingers hurts the forearm flexors.
Exactly. And you need a careful neuro exam, sensory, motor, distal to the compartment. Loss of two-point discrimination can be an early sign. But the chapter warns the clinical exam isn't foolproof. Its absence doesn't rule it out completely.
So if the exam isn't 100% clear, measuring pressure helps.
Definitely. Measuring intracompartmental pressure, ICP. The exact number threshold is debated, but the trend is towards dynamic thresholds, comparing it to the patient's blood pressure.
How does that work?
Generally, if the compartment pressure gets too close to the diastolic pressure, or if the difference between the mean arterial pressure, MAP, and the ICP drops too low, say below 30 or 40 mmHg, that suggests perfusion is compromised and fasciotomy is needed.
Are there unusual spots to watch out for?
Yeah, the thigh can get it, usually with femur fractures. And the gluteal region sometimes after pelvic procedures, hip surgery, or just prolonged compression. Gluteal is nasty because it can cause rhabdo, kidney failure, and sciatic nerve injury.
What about prevention?
Mm.
For stopping systemic problems if it does happen.
Prevention. Well, there's research on drugs to blunt reperfusion injury, mannitol, allopurinol, but mostly animal data, not standard practice yet. More practical is first aid to hypoxic cells. Keep blood pressure up, cut off tight bandages, limb at heart level, give oxygen. In surgery, maybe lower legs periodically if they're down for a long time.
And preventing kidney failure from muscle breakdown.
Aggressive 5V fluids. Sometimes mannitol or bicarb to force diuresis and alkalinize the urine. Gotta watch electrolytes closely too, especially potassium, which can shoot up dangerously high. May even need dialysis.
So the definitive treatment is fasciotomy, surgically releasing the pressure. When is it absolutely necessary?
Key criteria. Clinically, a tense compartment with that severe pain on passive stretch, or any new neurological deficit in the limb. That's pretty much an absolute indication.
What if it's just tense, but no neuroscience or major pain on stretch?
That's tougher. Might need serial exams or measure pressures. Or if you strongly suspect it's going to get worse, you might do a prophylactic fasciotomy, especially after prolonged ischemia, 6-H'ers, or combined artery vein injuries. ICP measurements help guide the decision too, especially in patients you can't examine reliably.
When would you not do a fasciotomy?
If the limb is clearly already dead, non-viable, no point then. And maybe in really severe crush injuries where releasing the pressure might cause overwhelming systemic problems like lethal hyperkalemia. That's a very careful judgment call.
Technique sounds crucial. Key points for different areas.
Lower leg is most common. Need to know the 4 compartments, watch out for the superficial peroneal nerve. Incisions need to be long, 12-20 centimeter full decompression. Usually a double incision technique, lateral and medial, is preferred over a single incision to reliably get all compartments and minimize nerve vessel injury.
Thigh, buttock, foot, forearm, hand.
Thigh usually needs 1 lateral incision for anterior-posterior compartments. Buttock is less standard, often longitudinal, might need sciatic neurolysis. Foot has many tiny compartments, needs dorsal incisions, and maybe a medial one for the calcaneal, avoiding plantar structures. Forearm, often a volar, approach releases volar lateral, maybe needs a dorsal one too. Carpal tunnel release is debatable. Hand has 10 compartments, needs tailored incisions, often carpal tunnel and dorsal interosseous releases.
And managing the open wounds afterwards.
Critical. Keep them clean, protected. Saline dressings initially for inspection, debridement. VC therapy is a good option too. Closure. Options are delayed primary closure, careful not to increase pressure, secondary intention, slow, gradual approximation devices, or split thickness skin grafts, maybe flaps if needed. Earlier closure, when safe, might reduce complications and hospital stay.
What are the outcomes, short and long term? And what if you miss it?
Early outcomes.
Right.
Mortality, 11-15%, major amputation, 5-21%. Wound issues common, especially if delayed 6 hours. Kidney failure, rare without major muscle death. Nerve deficits happen, maybe 7-36%, most common in forearm.
Long term.
Depends on function at discharge. Numbness around scars is common, 77%. Tethered tendons, ulcers sometimes. Chronic venous insufficiency is frequent, almost 50% because the calf pump is damaged. Late amputation still happens, 7.5%.
And if it's missed?
Devastating. Worse nerve damage, higher amputation risk, kidney failure. Delay 12 hours, complications soar. 36 hours, usually amputation. After 3-4 days, decompression is often contraindicated due to infection necrosis risk. Volkmann contracture in the forearm is the classic result of missed compartment syndrome there.
What about chronic exertional compartment syndrome, CECS? Different beast.
Totally different. This is exercise-induced pain tightness, usually lower leg, in athletes like runners. Pressure goes up during exercise, causes temporary ischemia.
Symptoms.
Pain comes on after 20-30 minutes exercise, resolves with rest. Maybe some numbness, weakness, often bilateral. Tenderness might be present.
Treatment for CECS.
Avoidance or surgery. Fasciotomy is often preferred so they can get back to sport. Only decompress the symptomatic compartments. Techniques vary: subcutaneous fasciotomy or fasciectomy, removing fascia. Outcomes seem pretty good. Pain relief in over 80% at 2 years.
Okay, last chapter. 106, Atheromatous Embolization. Sounds tricky to diagnose.
Very tricky. It's often called the Great Masquerader. Basically, cholesterol crystals break off plaques, usually from the aorta, and shower down into small arteries in various organs. Multisystem, often under-recognized, high mortality.
Other names for it.
Cholesterol embolization, blue toe syndrome, used interchangeably. Management is mostly supportive. Treat the affected organs. Stop more emboli, manage risk factors. High index of suspicion is key.
What actually happens with these crystals?
They're tiny, needle-shaped, lodge in small arteries, often at bifurcations, triggers immediate inflammation, PMNs, eosinophils, then chronic inflammation, fibrosis, vessel blockage, causes distal ischemia, infarction.
And this explains delayed kidney problems.
Yeah, that inflammatory process contributes. The crystals themselves can hang around for months.
So clinical signs depend on where the crystals go.
Exactly. Ascending aortic source, brain, eyes. Descending thoracic, abdominal, viscera, legs. Bilateral leg signs point to a proximal source. Big plaques can cause major events. Microemboli cause milder, maybe systemic illness. And that delayed onset, especially renal failure up to 8 weeks later, is classic.
Kidneys and GI tract are common targets.
Kidneys are second most common. High blood flow near the aorta might cause 5–10% of inpatient acute kidney failure, but often missed. Causes inflammation, vessel thickening, fibrosis. Can present as acute, subacute, or chronic kidney failure, even needing dialysis. Hypertension is common too.
Prognosis for kidneys.
Historically grim, but spontaneous recovery can happen. Worse if patient has heart failure, CKD, older iatrogenic cause, or lay-GI involvement too. Statins seem protective.
Angina.
Third most common at autopsy, but often missed clinically. Can affect colon, small bowel, stomach, pancreas, liver, gallbladder. Symptoms like abdominal pain, diarrhea, bleeding from ischemia infarction. Endoscopy, often nonspecific, but biopsies might show crystals. GI involvement usually means widespread disease, poor prognosis.
And brain, other areas.
Brain, TIA, stroke, altered mental status, headache, dizziness, encephalopathy, diffuse. Spinal cord, rare. Suspected in elderly with acute kidney failure plus encephalopathy after an aortic procedure. Imaging might show small infarcts. Can hit almost anywhere. Heart, angioedema, lungs, rare, spleen, bone marrow, muscle. General symptoms too. Fever, weight loss, myalgias.
Diagnosis sounds like putting puzzle pieces together.
It is. High suspicion is paramount, often clinical. Precipitating event plus characteristic end organ symptoms plus maybe peripheral signs like blue toes or levator reticularis, that mottled net-like skin pattern.
Lab tests helpful.
Mostly nonspecific signs of organ injury, BUNCR, LFTs, amylase, CPK. Eosinophilia is common, up to 80%, but transient. Inflammatory markers, CRP, ESR up, maybe anemia, thrombocytopenia. Urine might have mild protein blood. Need to differentiate from contrast nephropathy, vasculitis, TTP, etc.
How do we treat it?
Mostly supportive. Avoid more inciting events like aortic manipulation. Control BP, heart failure, dialysis if needed, nutrition, and aggressively manage risk factors. Antiplatelets, statins, ACE inhibitors, RRBs.
What about specific medical therapies? Steroids.
Corticosteroids are controversial. No routine recommendation, maybe for severe multisystem disease, but data is conflicting. Statins seem beneficial, especially for skin signs and renal disease. Probably plaque stabilization, prostacyclin analog, vasodilator, antiplatelet. Some reports suggest benefit for distal limb kidney ischemia.
LDL apheresis.
Can help skin manifestations, maybe improves blood flow, reduces inflammation.
Drugs.
Aspirin, dipyridamole, etc. No controlled trials show clear benefit, but optimal risk factor modification, antiplatelet, statin, ACE, IRB is crucial for all these patients with atherosclerosis.
Any role for surgery or endovascular therapy?
Limited role in removing the source, sometimes covered stents for aortic plaques causing emboli, extra anatomic bypass for severe limb ischemia if the source can't be fixed. Embolic protection during interventions is vital. Lumbar sympathectomy might help pain and toe gangrene. Spinal cord stimulation sometimes for pain microcirculation. Pain specialists can be very helpful.
So a complex multi-system disease of advanced atherosclerosis, often missed. Supportive care and risk factor modification are key.
That sums it up well. Prognosis varies worse with visceral renal involvement than just extremity-limited disease. But overall mortality can be high, often from cardiac, CNS, or GI issues.
Wow. Good. That was a really thorough journey through some incredibly challenging areas. Let's try and boil down the key takeaways.
Yeah, I think we hit the dual nature of acute limb ischemia, embolic versus thrombotic, but stress that rapid clinical assessment and severity classification are what really drive management.
Right. And the evolving role of imaging like CTA and the different intervention options needing that tailored approach.
And compartment syndrome, understanding the pressure problem, spotting it early, and knowing that timely fasciotomy is absolutely crucial.
And finally, atheroembolism, that subtle but serious great masquerader, recognizing it needs high suspicion. And treatment is mainly supportive and about managing underlying risks.
Exactly. Covers the core messages from those chapters. So, thinking forward. Despite everything we know, Amputation and mortality rates for acute limb ischemia are still stubbornly high. What's the next frontier? What novel diagnostics or therapies might actually move the needle significantly on outcomes? Or, as endotech keeps improving, how will that decision making between open and endovascular really evolve and become more personalized? Lots to think about.
Definitely. These remain huge challenges in vascular surgery, always pushing us to find better solutions.